Hello, ladies. Is life looking different for you in light of COVID-19? If you're pregnant, you may have many more questions. And in today's interview, I take your questions about pregnancy, delivery, and COVID-19. So please join me as I interview Dr. Danielle Kiko, OBGYN in Canton, Ohio, who shares from her 13 years of experience some insights as she answers your questions. So, Dr. Kiko, have you seen some changes in your practice and how life is just functioning and how you're delivering and that type of thing right now?
Yes, it has. Our office hours have been cut back because mostly we're just seeing OB patients. The OB patients, some of them we're seeing in the office and some of them we're doing telehealth visits with. There's a lot of concern from our pregnant patients about what coronavirus means for them and what if they get it and then if they should stop working, especially from our healthcare providers, what precautions they should be taking, if any.
I've also heard that there has been, in concern, temptation to cover up symptoms and not say anything and not be upfront when they go into the hospital. But again, it's seeing the bigger picture that this puts you at risk and that your staff at risk and mom and baby and others. What would you say?
Yes, I would not recommend not bringing up symptoms. If anybody has any symptoms, even if they're not sure about it, they should definitely bring it up. This is something that's very serious and can be very serious for newborns if they were to be exposed. It doesn't seem to appear that there's transmission from mom to baby while the baby is inside, but there has been transmission from mom or dad to babies once the babies are born. And so the concern with a visitor having symptoms or the patient having symptoms is that exposure to staff, which then if they don't know, they can't wear proper protective devices and really they shouldn't be allowed in. Now, the patient is a different story. The patient has to come in, but then the patient would be given a mask and be put in a special room to help protect the hospital staff that's taking care of her. And it also influences the care of mother and baby afterwards. If mom were determined to be what's called a person under investigation, meaning someone we're concerned has COVID and we've tested them and we're waiting on results, or if mom has been determined to have COVID, then after delivery, the recommendation is that from the CDC is that the baby is placed in a special negative pressure room, which is a special room that we use in patients who have this contagious disease through respiratory secretions. And if the mom refuses to have the baby separated, then they maintain in the same room as mom, try to maintain 6 feet apart, and have one of the staff members feed the baby. Mom can still breastfeed as far as pumping and then having someone else feed the baby the breast milk through a bottle. But we do still encourage moms to continue to breastfeed.
That's great to hear. It sounds like the accommodations are trying to be met and making the best out of a situation that has a lot of restrictions put on it. I've heard that discharges from hospitals are happening a lot quicker. Are you noticing that also, maybe 24 hours or 48 hours after delivery?
Yes, a lot of women are requesting to go home. We've sent some C-sections home the day after their C-section per the patient's request, just because they want to get out of the hospital and back to their families as quickly as possible.
Will the father be able to be in the delivery room due to the COVID-19 restrictions? Or, I'm scared that my husband will have a cough and not be allowed to come into the hospital with me. What would you say in that response?
For the most part, most hospitals are allowing one visitor with the patient on maternity for the length of the patient's stay. It is locally dependent on what your hospital says, but for the most part, most hospitals are allowing one visitor. Some hospitals require that visitor to stay the entire time. Our local hospitals are not requiring that, but all visitors are screened, as is the patient, for signs of COVID. And a cough alone is not necessarily concerning for COVID, but a cough associated with a fever or a cough associated with shortness of breath, or a fever associated with shortness of breath. So it's more of a combination of symptoms. And then that would prompt, if there's a positive answer, that would prompt further questions.
Thanks for all that information about the current situation. Let's jump into the next question, which says, why choose a C-section over a vaginal delivery? Some women are saying, I'm scared to have a vaginal delivery, so I'm going to choose a C-section. What would you say to the woman that is fearful going into a vaginal delivery and feels that a C-section might be safer or easier for her?
So the first thing that I typically do is find out what exactly their concerns are. For some women, it's the concern of the unknown. They don't understand what's going to happen during labor, or their friends tell them stories about their experiences. And I just encourage women too to take those kind of with a grain of salt, because sometimes a patient's perspective is a little bit different than what actually occurred, or their understanding of something that occurred, about why that occurred and why it may have been the best case scenario for them, even though it was a poor experience for them. So I encourage them to try to talk to me, or talk to, if a different patient, to talk to their healthcare provider about their concerns and what their friends have been telling them, so that we can kind of dispel the myths that are out there. Some women are scared because they feel like they have more control with the C-section than what they would with a vaginal delivery. And so a lot of that is just education on what happens during the labor process, all the different types of monitors and things that can take place, what happens at delivery, who is where, what happens with the baby afterwards. And in those patients, I really recommend that they consider doing a prenatal childbirth class, so that they can be more comfortable with that. Some women are concerned with that if I have a C-section, my vagina won't look different, or if I have a C-section, my I won't leak urine someday, or if I have a C-section, I have less chance of things falling out down below. And really, all the literature has shown that none of those things are true. C-sections are not protective against any of those things happening.
Go along with that question, what do I do if I'm scared about a vaginal delivery?
Again, it depends on why they're scared of the vaginal delivery. For the most part, vaginal deliveries are the risk of complications is less with a vaginal delivery than with a C-section. There's less risk of bleeding. There's less risk of infection. There is a quicker recovery time. Um, there's really not any benefit to a C-section over a vaginal delivery. So it's kind of drilling down into why they're scared of a vaginal delivery.
I think often women are also concerned about the pain with a vaginal delivery. Um, so an epidural is a great option for pain control. And another woman asks, will I feel it when I get an epidural?
Sure. So, whether you have a vaginal delivery and choose to have anesthesia, such as an epidural, or whether you have a C section, with a C section, we don't put patients to sleep. So, the patients are awake during their C section. And so, they either have an epidural or a spinal, and for a C section. So, a C section doesn't avoid the epidural or the spinal. Patients still have to have that. We don't put patients to sleep because there's increased risk to the baby, as we have to get the baby out within 3 minutes. Otherwise, the medication that they give mom to go to sleep with gets to the baby, and the baby comes out not breathing, and needing to be resuscitated. So the epidural, and the spinal, both of those needles that they use are much, much, much smaller than the needle that they use to put the IV in. And so most patients will say that their epidural or spinal hurt way less than what putting an IV in hurt. In addition, so the difference between an epidural and a spinal is the epidural, they use a needle to get to the space around the spinal canal, which has the spinal cord and the spinal fluid in it. And once they get there, then they thread a catheter into that space, and then they take the needle out. And then they can give the medication through there, and they can continually dose the medication through the epidural. And that's most commonly used for a vaginal delivery. Some hospitals do them for C-sections. versus a spinal, they put the needle in directly into the fluid that surrounds the spinal cord, inject the medication. The patient is instantly, their feet start to feel warm. It slowly, the numbness starts to creep up until it gets just underneath their breasts. And the spinal needle is immediately removed. So most patients tolerate those very well. Patients who are laboring and then choose to get an epidural for sure say they don't feel the epidural because the pain of the labor is way worse than what the pain of the epidural is.
Both of my deliveries were 10 and 12 years ago, and I was trying to think back to my epidurals, and I remember there was some discomfort, but not intense pain. So I would definitely agree with you there. So another lady asks, is it true that some doctors extra stitch you when you tear without even asking, also known as a husband stitch? I think they're alluding to after a vaginal delivery and there's a tear.
So that is not true. Back a long time ago, doctors and patients had a different type of relationship where patients just did what their doctor said. And that's really not the case anymore. And that's kind of a lay term and a very common misconception or myth, I guess I should say, that there's such a thing as the husband stitch. There is no such thing as a husband stitch. What women refer to by that is putting a stitch in there to make the vagina a little tighter, implying that their vagina has been stretched and won't ever go back to how it was without putting an extra stitch in there. And so, no, we do not do that.
I know with my delivery, it's been a few years, I had an episiotomy and a tear. What's your opinion on episiotomies?
Right. And the episiotomy rate in the United States now is less than 2%. So the episiotomy rate's extremely low because we know that women don't recover as quickly if they have an episiotomy. And every episiotomy that I've done, I've been in practice for 13 years. I could probably count on one hand, and they've all been related to the shoulders being stuck at the time of delivery or the baby being in distress. And the only thing that's holding the baby in is the patient's tissue. And like I said, 13 years, I maybe have done five, three, four. It's less than five for sure. So it's very, very unusual that we do an episiotomy.
I think it's also reassuring for women to know that research is going ongoing and techniques and advances in medicine are being made almost every day. So, one lady asked, I'm afraid of having a water birth because it's not really in a hospital, but I really want one. How safe is a water birth in comparison to a hospital birth?
I'm thinking that by water birth, they're assuming that they're meaning a home birth, because many hospitals have the availability to do a at least to labor in water. Most hospitals don't do true water births where you deliver in the water because there's been an increase in infection and complications during that, to the baby and to mom. And so most hospitals don't allow you to deliver in the water tub, but they will allow you to labor in the water tub. But in general, a home birth, while they can be an okay scenario for someone who is low risk in pregnancy, the problem that we find is that women are low risk until they're not. And they can become not low risk very quickly. So we see it many times where patients are very low risk and they end up having a postpartum hemorrhage, or they have a shoulder dystocia where the shoulders get stuck after the head comes out. And those are emergencies that midwives and lay midwives are not capable of handling. And if those occur in the hospital and a midwife is caring for the patient during that time, there's always an obstetrician who can jump in and use their skills that we were trained with, to take over from there. So we really discourage to do home births, unless it's a home birth with a physician, but even still, you lose all those resources that are available at the hospital. But if someone's wanting to do that, they really should talk to their OBGYN about what their wishes are. Do they want to be unmedicated? Do they want to be able to get up and move around? Do they want to not have unnecessary medications? Do they not want their water broke? And all those things usually can be accommodated in a hospital setting so that you kind of get the best of both worlds. You get the delivery with minimal interventions and hands off with the background safety net of the hospital.
So, when would you suggest a woman discuss this with her doctor? Is this a first trimester conversation, or do you wait until the third trimester and you're towards the end of your last few weeks of your pregnancy?
Well, I think it's a good thing to discuss in your first visit, just some of your thoughts to make sure that you've chosen a provider that is willing to accommodate your wishes or work with you on that. I mean, there are doctors are human, so there are some doctors who are very set in their ways and they don't want to participate in births like that. But for the most part, I'd say the vast majority of us are do not have those thought processes and are very willing to work with patients. Our goal is a healthy mom and a healthy baby, and not one or the other, but both. And so whatever we need to recommend for the patient or to do for the patient is really what we want. So I would initiate that conversation at the first visit and then again readdress it in the third trimester.
That's great information. Next question. What can I do to prevent tearing with my first?
So some of the best things that you can do is to make sure that you have a good pelvic floor support to start with, and to make sure that you're physically active. Women who are physically active and physically fit have a much better pelvic floor, typically, and their ligaments and their muscles are stronger. And then there you can use things like coconut oil or olive oil, or mineral oil to massage the area between the bottom opening of the vagina and the rectum. And that area is called the perineum. And we usually recommend that you start doing that in the third trimester, usually once a day. And then as you get closer to delivery, to massage that. And you just warm that area with like a hot compress, and then use that oil to just gently massage that area to keep those muscles soft and supple right there in that skin as well. It also, the best way is to listen to your OBGYN. If they're telling you during the pushing phase, as the head is coming, to stop pushing, it's really important that you try to do that, because what we do is we try to give the perineum some support, and we try to do a lot of that massage while you're pushing also, and as the head's coming, and we try to allow the baby to just naturally and slowly stretch that perineum, versus if a mom is uncontrolled and just pushes out a baby really hard and really fast, there's really no opportunity for us to help protect the perineum.
Let's continue on with the same subject. The next question is, I have had a third degree tear with my first. Am I going to tear that badly again?
Well, there's really nothing that can predict the recurrence. A lot of it is dependent on why they had the third degree. Some women, there's just nothing we can do. It's just the nature of how it happens that sometimes they get that third degree. But again, doing those things that we just talked about to try to help prevent it the next time, especially third degrees are where you tear partly through the sphincter that controls whether your stool comes out or not. And so when that occurs, that weakens that, and that tissue there is very firm, and it's very non um, stretching, I guess I should say. And so that massage is even more important than before. But you really should make sure that your OBGYN knows that you have that history, because if you do have another third degree, or worse, a fourth degree where you tear into the rectum, then your chance of having incontinence of stool is about 50%, meaning you're passing stool when you don't even intend to.
The next question a lady has is, I have a low placenta at 22 weeks. Should I be concerned?
So this is a very common thing that we see. There are different types of Placental positions. The placenta is shaped, if you think of it, if you look at a picture of a uterus with the placenta, it looks kind of like a moon in your uterus. It's crescent shaped just because of how it's actually a disc, but when it lays up against the uterus, it forms a crescent shape. If the tip of that placenta or the crescent is close, within 2 centimeters of the cervix, but more than 1 centimeter from the opening of the cervix, then patients can still have a vaginal delivery, but there is an increased chance of bleeding. If it's less than 1 centimeters, patient at the time of delivery, patients should have a C-section because the risk of bleeding is extremely high. Or if it's completely, the whole placenta is completely laying over top of the cervix, then patients are delivered via C-section early for that reason, because babies can't come down through a placenta. But most of the time, 90% of the time, the placenta laying too close to the cervix has resolved itself and moved up more than 2 centimeters away from the cervix by 28 weeks. So most of the time, it moves up and out of the way by 28 weeks and it is not a concern at all.
I think as all women are anticipating delivery, the common question is, how do I prevent tearing? What is the best laboring position? Because there's a lot of discussion about this. So what's your opinion?
The biggest thing is just asking your nurse as she's pushing with you, to make sure that she's massaging that perineal area, or as you're delivering with your OBGYN, that they are able to massage that perineal area. Um, the the positioning, if you're on your back or on your side, you're more likely to tear from that perineal area. If you're on your hands and knees, you're more likely to tear where your urethra, where your pee comes out, or through your clitoris, or through one of the labia, which are the lips of the vagina, because that's the direction that the baby's coming. There's a balance that your OB does between supporting the perineum, but if we see that we're supporting the perineum, but that's going to lead to you tearing through your clitoris or your urethra, then we let off the perineum a little bit because it's less traumatic and less difficult to repair and less longer term problems to tear through the perineum than it is to tear through the urethra or the clitoris. Yeah, so for actual laboring, it depends on how we feel like the baby's position. If the baby's position is what we call sunny side up, where the baby's going to come out looking up towards the ceiling, then we try to put the patient far on one side and use what's called a peanut ball, which is a big ball that looks literally like a giant peanut. And we put that between the patient's legs to help keep the pelvis open, and it helps the baby to rotate around so that the baby comes out facing the ground, looking at the ground. Because moms have to, the pelvis was designed for babies to come that way. And so moms have to push less. There's less trauma during delivery that way. Most OBGYNs would prefer that patients are on their back or on their side for delivery, in standard deliveries, just because it's looking at things is more the way that we're used to seeing them. B, during the delivery process, we do standard maneuvers, and they were designed to do it in that direction. And then the other part of that is the stool from mom is below the baby's head. I've had several cases of delivering on hands and knees where the stool's coming out and hitting the baby in the head. But if the shoulders are stuck, there are times where we flip mom onto hands and knees as a maneuver to try to get those shoulders out too. But as far as reducing tearing, not as much. It doesn't really depend on what position they labor in.
Thank you, Dr. Kiko, for all this great information. I want to ask you one more question. What's one simple step that you would leave with a pregnant woman looking forward towards her upcoming delivery?
I would just recommend that you take the initiative to talk to your OBGYN about your concerns and your questions, and things that you've heard, and to discuss that with them so that your mind can be put at ease, and also to keep an open mind during that time. that everybody's ultimate goal is that you are a healthy mom and a healthy baby. And everybody wants this picture perfect delivery. And unfortunately, sometimes deliveries just aren't like that. Babies don't always read the textbooks and read nature about how things are supposed to happen. And so the delivery moment is such a small moment in the lifetime of your relationship with your baby, to be open-minded to listening to your body and your baby in conjunction with discussing your concerns and listening to your provider's viewpoints as well, to get you that long-term relationship with your baby.
Once again, I can't say thank you enough, Dr. Kiko, for joining me on this interview today, and so many women that are going to feel more confident going into delivery, that have had their questions answered with real facts and sharing with your insight and your experience. So thank you again.
You're welcome.
Thanks so much, ladies, for listening. And thank you again, Dr. Kiko, for all of your insight and wisdom and experience. Again, if you're in the Canton, Ohio area, Dr. Kiko has a private practice named Generations Women's Health, and I know that her patients love her, and you could be one of her patients as well. Ladies, if you're also looking for more information, be sure to check out my website, onesimplestep.today, or my YouTube channel where I have longer videos about different health issues that women face. And that channel is One Simple Step Today. And I'm also on Instagram at the same title, One Simple Step Today. Have a great one and take that one simple step today for greater health and healing.